Hi, this is Brian Kim. I want to share with you this case of a patient who's referred for a dislocated IOL. It turns out this IOL was also upside down, and it was also a silicone lens. And as I've said on this channel multiple times, silicone IOLs are quite slippery, so it's a little bit of a challenge. With the lens being upside down, it's possible that this patient dealt with pressure problems after his original surgery. And so we're going to take this lens out and perform my Yamane technique. And so you can see this lens is upside down. You can see the curve of the haptic. I make my limbal mark on the right side and then the left side using the cannula to find 180 degrees apart. And this is a fixed caliper by Epsilon. Again, I don't have any financial interests. And I indent 2.5 millimeters posterior to that limbal mark and then 2 millimeters adjacent. And then I ink those indentations. Again, indenting 2.5 millimeters posterior to the limbus on the left side in similar fashion, and then 2 millimeters adjacent, and then inking those indentations. This is the back of the trocar needle, indenting 3.5 millimeters posterior to the limbus, tunneling about 3 millimeters with the needle towards that indentation, staying nice and flat to get a nice scleral support, and then diving down. Making my incisions, I'll be making several incisions to take the lens out, but as well as incisions for the iris hooks. You saw the subincisional scleral incision I made so that I can place my iris hook in. And again, I'm going to retract the iris in a rectangular configuration. And why is that? Because I only care about retracting the pupil in the area of action to help me see to place the haptics into the needles. And the rest of the incisions are, again, a contralateral limbal incision to externalize the leading haptic, and then my AC maintainer. This is dispersive viscoelastic. And then the 3 millimeter main incision, make a vertical groove, tunnel through the cornea, and then I enter. These are 2 microforceps. I'm going to grab that haptic, and you can see again that the lens is upside down, pulling that proximal haptic into the angle. Inching my way towards the optic as I do this. Try to get it up. There we go. And then that distal haptic using 2 forceps to kind of inch it across. There you go. Now the entire lens is in anterior chamber. So this is a little bit different because it's upside down. Going to cut the lens in half. Again, I'm holding it with the IOL holder. Switching hands. And this time I'm going to pull the left piece out because that makes most sense, because as I pull it out, the haptic comes out nice and straight. And then the other piece, of course, the haptic is towards me, so I'm going to grasp the haptic and then pop it out. And then pull the optic out. Placing iris hooks to retract the pupil. Again, I was strategic in the placement of those incisions. And again, I'm going to retract the pupil in a rectangular configuration specifically retracting in the area to help my view to thread the haptics into the 30 gauge thin-walled needles. So this is the scleral incision, subincisional to my main incision to place that iris hook. And when you do a lot of iris hook surgeries, you get really comfortable with manipulating those hooks. You're able to pull the plunger back. In this case, you can see that I'm having trouble reaching the pupil edge. And why is that? Because I pushed all that dispersive viscoelastic and it pushed the pupillary edge back. And so the solution here is using microforceps to pull the hook down. And as I do this, I'm able to retract with my left hand and hook the pupillary edge. So using a two-handed maneuver to get that hook in place. And this is the final hook, making sure the plunger is pulled back and then just twirling the hook to get it underneath the pupil and then retracting. This is a 22 gauge thin-walled needle by Epsilon. Again, I don't have any financial interests. And then performing anterior pars plana vitrectomy. Pushing some dispersive viscoelastic through the main incision. This is intracameral triamcinolone. There's some vitreous right there at the wound edge. Performing some limbal vitrectomy. And then pars plana vitrectomy. This is a 25 gauge needle. I'm bending it fairly close to the tip, making sure the bevel is facing to the right. This is the right side needle. I'm bending it about 9 millimeters from the tip, making sure that the bevel is facing towards the main incision. All the needles are mounted with BSS. It's important to minimize bubbles. This is the left side needle, bending it at the hub, making sure the bevel faces the contralateral limbal incision. This is the emerald cartridge, injecting cohesive viscoelastic through the barrel and on the platform. Placing the Sensor AR40 lens on the platform, making sure the optic is seated down before bending the wings. As you bend the wings, the optic bends backward, the trailing haptic comes out to the back, and the leading haptic straightens out through the barrel. Placing the cartridge into the injector, making sure the trailing haptic is up and away from the plunger. And then I'm ready to go. Placing the 25 gauge needle through the contralateral limbal incision, placing the injector through the main incision, making sure both bevels face each other. My assistant advances the lens. As the lens comes out, the leading haptic comes out. I dock the haptic on the bevel of the needle as she advances the lens even more. And then I try to turn the needle so it faces a haptic. And as she advances the lens, I withdraw the needle. In this case, I withdrew prematurely. So I have to dock the haptic on the bevel of the needle again. As she advances the lens, now I'm able to withdraw the needle and the haptic comes out. I take over, deliver the optic. Turn off infusion, pushing dispersive viscoelastic to coat the cornea and push the optic back. Pulling on the leading haptic outside the eye so the optic is pushed away from me to give me better access to the trailing haptic. Holding the trocar cannula, stabbing the conjunctiva and sclera at the first mark, tunneling 2 millimeters and then diving down. Using smooth microforceps, first I pull the leading haptic out some more, pushing the optic away, and then I slide the trailing haptic sideways to the left, carefully placing it into the eye, docking the haptic on the bevel of the needle. Two pushes and then I'm in. Disengaging the needle from the syringe. Internalizing the leading haptic, placing it into the angle. Holding the eye with contralateral fixation. Stabbing the conjunctiva and sclera at the first mark with the left side needle, tunneling 2 millimeters and then diving down. Using smooth microforceps, grasping the trailing haptic. You see how I'm holding the needle to face the haptic and not the other way around. So I've twisted the needle to face the haptic. Dock the haptic on the bevel of the needle, 2 pushes, and then I'm in. Withdraw both needles a little bit, but then focusing on the left side needle, withdrawing it completely. As I withdraw the needle, I limit how much haptic comes out. Cauterize the tip. You can see how nice and flat the haptic is sitting on the sclera. Do the same thing on the right side, again limiting how much haptic comes out as the needle is withdrawn. Cauterizing the tip, again nice and flat position of the haptics. This is not the flagpole sign, which means I'll have a nice scleral support, which best approximates an in-the-bag IOL position. Pushing both haptics flush to the sclera, reapproximating the conjunctiva. You can see well-positioned lens, which should give me a great refractive result as well. Taking all the iris hooks out, holding the hook, pulling the plunger back, twisting it so that it disengages the pupillary edge. Performing some more pars plana vitrectomy. Performing a surgical PI temporally, again making sure that you cut in such a way that you can visualize the PI. Performing limbal vitrectomy, but mainly just trying to get all the viscoelastic out. Closing the main incision. Taking the trocar cannula out, massaging the incision, turning on infusion. Take out the AC maintainer, hydrate my incisions, and that'll be the end of the case. So again, this patient had a dislocated upside down silicone 3-piece IOL. I was able to place strategic iris hooks to help me with the case. So I took the lens out first before placing the iris hooks. Why? Because when you're able to pop the lens into the anterior chamber, it reduces the chances for the lens to fall into the vitreous. So having a smaller pupil does help you with these cases when it comes to taking the lens out. But once the lens is out, and you saw that the lens was upside down, I had to cut it. And it's a silicone optic, so it's a little bit more of a challenge to take it out. I bisected it completely and took each piece out. Again, why? Because I had, again, a small pupil. So this really gives me more security that the pieces won't fall out into the vitreous space. And then place iris hooks strategically in a rectangular configuration. And then I was able to perform my Yamane technique, again, using a 25 gauge needle passive docking technique to externalize the leading haptic, and then again being very intentional about stabbing the conjunctiva and sclera and tunneling 2 millimeters through the scleral tissue so that the haptic has great scleral support. I also made sure I docked the haptic on the bevel of the needle, making sure I turn the needle towards the haptic and not the other way around, which will minimize any potential damage to the haptic. I attack the trailing haptic first. Why? Because I'm able to turn and push the optic away from me because the leading haptic is outside the eye. I have a lot of wiggle room and ability to manipulate and place that trailing haptic through the right side needle without causing any stress on the haptics. And then I'm able to internalize the leading haptic and then executing the scleral fixation with the left side needle using a 30 gauge thin walled needle. And then again, turning the needle to face the haptic, docking the haptic on the beveled needle. Again, 2 pushes is all you need. You don't need a lot of internalizing of the haptic. I do think that's part of the problem with the other lens, the C2 Lucia. With this, the needle grips the haptic so much better, and you don't worry about it slipping out. I've never had it slip out with this lens, so I have a lot of confidence that I'm not going to lose a lens. Again, this patient did quite well with a dislocated upside down silicone lens and with my Yamane technique using the AR40 lens. So I hope this was helpful to you, and I thank you for your attention.